I dig it. Alright. This is where we're starting.
Mute on entry and everything and stuff.
Yeah, the new entry.
I'll double check.
Anyone can share.
We don't want anybody to share.
You don't want to share their screen.
We're going to go by. Oh, share their screen.
Yeah, absolutely. Their screen may come up.
What a lovely, lovely time. God, Susan, that's just really annoying. Why is it so annoying? Why do you think really the biggest thing is like that system? That web
Well, are you doing a presentation? Sammer? Sammer, can you do my part too?
Hello, everyone. Welcome to part 2 of our 2017-18 QI Project Grand Rounds. Just once again, I want to thank Drs. Pyle and Connors for, and Dr. Watts for their administrative support of our program, and Dr. Nysliak and Fralkus and Mansur and Margolius for their mentorship, and for and to all of you who worked on these projects. Thank you for your hard work and your commitment. Today we have three more projects to present. The first one will be goals of care discussion in the outpatient setting, a team that I'll call Team Let's Talk About Life. And the second one will be osteoporosis screening, a team I'll call No Bones About It. And lastly, we have a faculty presentation. We had a group of faculty that had the opportunity to take a lean course in Columbus just this past January. So ours is a work in progress, but we are a team. This is your brain on drugs. So with that, we'll get started, and we'll have about 12 minutes per group, with a couple minutes for questions afterwards.
Oh. Hello, welcome. So I'm Andrea, and this is our discussion of goals of care in the outpatient setting. And I'll let you guys introduce yourselves.
And I'm Samer Shaker, and
I'm Alex Sapik. Muhammad Abrahman.
All right, so for our QI project, we actually had started off trying to do something else. We wanted to, after getting started off in the critical care unit, we wanted to talk about increasing the rate of referrals to pulmonary rehab. We very quickly discovered that that was something that was probably not something that we could do in the QI project, because the main holdup was they have to see a pulmonologist before doing rehab. So we then changed over. We talked about other things that we were experiencing in the critical care units, which brought us to our topic today, which is goals of care. So starting off with the background, we found that goals of care discussion can often be an uncomfortable topic between not just healthcare providers, but also the patients themselves. Our society and culture is not one that likes to talk about death, and we prefer not to dwell on it. So oftentimes when we do have these discussions, it's when one is critically ill, and it's probably past the time that we should have had it. There have been studies that have been done, particularly with oncology and things like that have shown that people that do have these discussions in advance do increase the satisfaction of patients and their loved ones when it comes to end-of-life discussions, and also it helps to reduce stress for medical practitioners when this has already been had and they're not the first ones that have to bring this up. Now, one of the things that we think leads to this being an uncomfortable topic is what people think of when it comes to CPR and end-of-life care. Because of multiple forms of mass media, think that there's a lot higher likelihood of there being success when one does chest compressions and has to be placed on or has a breathing tube placed. And there have been studies that have been done that have shown that maybe for mass media, the rate of success of this is about 75%. Now, this compares to what it actually is in the real world, which is closer to 15%. And those that do survive often are at increased risk for complications. So here at Metro, the way that code status discussions are commonly had is when a patient comes in, we ask them about their code status, provided that they have the mental capacity to talk about this at that time. As a result, patients often become full code because they interpret this as, we want to do everything we can, why would we want to limit that? And it's also, for them meeting us for the first time, it can be a bit of an awkward discussion. We are a stranger meeting them for the first time, and they don't know us, they don't know our intentions, they can sometimes be a little mistrustful, especially if what we're telling them is that what may be best for them is not proceeding with what we call full code here in Ohio. So what we started to wonder is who would be better to have this conversation, and we thought that it would be someone that was not a stranger to them, someone that they follow with on a regular basis. Well, we thought it would be their PCP that was best equipped for this. So for our QI project, we talked about ways that we can encourage our PCPs to have this code status discussion, specifically with the residents in the resident clinic. This is something that no one is under any obligation to have. So although we've had a mention that random talks for the last 2 years, there's no motivating factor, no reason for people to take the time out to have these talks during their continuity clinic. We're often pressed for time and are unable to get everything done regardless without taking this into account. But we thought that since the PCP is the most trusted provider for these patients, maybe they'd be the best to have this discussion. So our aim was to increase the amount of residents that had this discussion with their continuity patients by about 20% over the course of 2 months. 2 months was picked because of our failed first attempt at QI.
All right, so the way we designed our QI project, we first sent out a survey to the residents in all 3 years, PGY1, 2, and 3, including our Med-Peds residents as well, because they also have continuity patients. And this initial survey had questions about how often they were actually holding a co-status discussion in their outpatient setting currently. So this was sent out in March, and so we found that only 26% of the respondents had held a co-status discussion throughout their time here at Metro Health. And this was a pretty significant value between the patients or the residents who had held the discussion versus who had not held a discussion. So we thought this was a good place to intervene upon as well to increase the incidence of them doing co-status discussions. A few other questions we asked for people who had done the co-status discussion was to ask them how many times had they actually done a co-status discussion. Was it only once in the whole time they were here, 1 to 3 times, or 3 to 5 times, or more than 5 times? Most residents who had said yes to saying that they did a co-status discussion was mostly just one patient. So our intervention upon that point was to send out a PowerPoint module, again, to all the residents in the internal medicine clinic and also the Med-Peds clinic about the importance of holding a co-status discussion, as well as some tips on how to hold a co-status discussion, including the different definitions of the terms that we use here at Metro Health. We also sent out reminders at our resident conferences to remind our residents to do a co-status discussion. Now, since this is a survey-based study, we wanted to have a way to validate that the residents were doing co-status discussions. So we had a box that was supposed to be for MRN stickers of the patients that the residents were holding discussions with, and they would drop a MRN sticker in that box. And that would be a way for us to validate that co-status discussions were being held, and we could calculate how many of those were present as well. So after 2 months, so in June, we sent out another survey which looked at the same questions again. The first one was how many co-status discussions had they held at this point. And there was a significant increase from 26 to 51% of residents who were holding co-status discussions in the outpatient setting. And this was also a significant, statistically significant value with p less than 0.05. A few other questions. This is the graph of the same topic as well. So pre-intervention, we had 26% of our residents holding discussions, and after our intervention of the PowerPoint and reminders, it went up to 51%. So another question we asked was to assess how comfortable our residents were feeling holding these co-status discussions. So although it appears that in the pre-intervention group, they said they felt about 73%, like 7 out of 10 was their level of comfort. And then after the intervention, it was 6 out of 10. But there was no statistically significant difference in these two values per se. So overall, the level of comfort did not actually change in our residents with our intervention. So then we further analyzed and asked, what do you think is causing, what is the barrier to holding co-status discussion in the outpatient setting? So a whopping majority of them said time was the most limiting factor, and that's this yellow piece of the pie here. And they said 52% of residents felt that they didn't have enough time to discuss the entire co-status discussion. Some of the residents felt that the culture was a barrier as well. So 15% of the residents felt that the patients that we were having, so for example, the Hispanic population did not want to have a co-status discussion when they were healthy because it was inauspicious. Another barrier was resident knowledge, which was the culture was 18%, that's this one, and the resident knowledge is 15%. So these are the people who thought that they didn't have enough training to hold appropriate co-status discussion in the outpatient setting, or they were not comfortable with the terms that we were using, the different DNRA, DNI, and all the different terms that we use at Metro Health. Some of the residents felt that the patients were too healthy to begin with to even hold this conversation. That was at 4%, so if they were young and healthy, they didn't think it was needed to hold a co-status discussion. Another barrier at 11% was patient literacy. So the patients themselves were just not quite understanding at which point in their life a co-status discussion would have to be held in the future. So those were the analysis that we got from the data from the survey, and we felt that this was important because, one, we were able to increase the percentage of residents holding co-status discussions in our clinic, so it is possible to do. But then it was interesting that the level of comfort hadn't changed at all, so which leaves a whole area of improvement for our residency is developing better skills in holding co-status discussions in the outpatient setting. There was a study that was done that was published in the Journal of Palliative Care Medicine in 2012, which was actually looking at simulations of co-status discussions in an internal medicine residency program. And they showed that a focused curriculum was actually able to improve performance of co-status discussions in resident programs. And they also showed that there was a retention of about 2 months of knowledge for these residents. So that's something that we could look into over here as well to help improve our residents' level of comfort with holding co-status discussions. And since the biggest gap was time was the most limiting factor for most residents feeling like they couldn't do a co-status discussion, having a simulated session would also help them learn how to do an efficient co-status discussion in the outpatient setting. The strength of our QI project that we thought was that we were able to increase the incidence with sending out a PowerPoint module about how to hold a co-status discussion, which goes to show that it is possible to hold these discussions in the outpatient setting. And then we were also able to identify actual barriers on what is preventing these discussions to being held in the outpatient setting. The limitation of our study was definitely our sample size. So the number of respondents that we had for our study was 33 initially before the intervention and 29 after the intervention. So the initial incidence was 26%. So to increase that by 20%, based on the power of the study, we would have had to meet 89 people to respond to our survey. Now, we don't have that many residents in our program, but a higher number than 33 would have helped in our data as well. The other limitation we had was, as with all surveys, there's always recall bias. With us, we tried to limit that with our MRN collection box. However, this was not used by our residents, and at this point, we don't know why. There was only one MRN sticker in that box at the end of our study. So that, I guess, further reminder to use the MRN box would have been helpful. So future directions, we kind of went over this, just improving how well our residents feel about co-status discussion in the outpatient setting would be helpful. And some other future directions that we were thinking of was including, to improve patient literacy, we could include pamphlets in the patient waiting room that they could read about, at what point co-status discussion would be important in their life. Because patients who don't have family members who have gone through a critical illness may not realize that this is something that could happen to them as well. Other few options that we had was including this as part of a best practice advisory as well, to remind the PCP to do a end-of-life care discussion as well to reduce physician stress. And that's about it. Yeah. Yes. Sure, yeah. So, I mean, have you guys researched data at all, the cultural barriers?
I think that's a great future direction for this project as well, because I don't think in our data we got enough to definitively say what all of those cultural barriers are, but we did get that information, particularly in the Hispanic population. But if we were to explore more into culturally targeted conversations, I think that would improve the efficiency and the success of these code status discussions.
Yeah, a lot of the cultural related barriers were mostly around patients' families thinking it was inauspicious to discuss death at a time when you're healthy, and also to make yourself DNR even though you're sick seems like against, even like religious reasons were a thing that came up, like it's against God's will to make yourself DNR when there's medicine available, was some of the quoted barriers. But I'm sure there are like studies out there on this already, I just haven't looked them up.
I was interested in, thank you. You gave an N, I think it was like 29 and 32 or something in that range. Was that the residents who were involved, or the patients?
That was the number of respondents to our survey. So there were 33 respondents initially that responded to our survey, and
but
then
I wasn't clear who the subject of the survey was.
Are the residents.
The patients or the residents?
It was the residents.
Okay.
Yeah.
So were they the same group?
No, we didn't match them.
Okay.
We just sent out the survey again to all of the residents, so we're not sure if it was the same resident who replied back or not.
Okay. Because one of the worries, of course, is when you educate somebody, it's when you're asking people basically what their perception is of how often they do this. It is an indicator of what's happening, but there's a great risk of bias, right?
Right.
And although the change was large enough that it looked like something happened, and it reassures me that it was a different group before and after that. But if you go back to do this again, it would be interesting to look at the patients that these people interact with, for a several-week period, and see how often you document those discussions.
Right, and that was our idea with the MRN collection box, was also to see if these patients were to be admitted, would that have helped their admission as well? Because that was our idea with this project, was to make their admission smoother if they are admitted at Metro Health again.
Yeah, and there also might be cultural influences among the residents. People come from different backgrounds and different approaches towards dealing with death and dealing with illness. So we're just as prone to those kinds of biases as our patients are, and it would be interesting to look at those, in a resident population. So, but good work. It isn't easy to do this, and you did a nice job.
Yes, Dr. Pyle.
So this is just an observation, not a question, but I think you guys have underscored probably the opportunity for some curricular elements addressing this. And I just wanted to point out that our Director of Communication Skills Training, Dr. Conda Panini, has those in the works. So that'll be rolled out in interactive form in the coming year.
Thank you.
Are we collaborating with our Innovation Center?
So we're looking into the possibility of that.
Hi, I just wanted to say the geriatric fellows did a project like this a few years back, so you might reach out to Mary Corrigan and get their data on the project. Plus, it would probably make sense for you to collaborate with them anyway. And they did it in the outpatient setting.
Oh, nice.
So.
That'll be great. Thank you.
Thanks, guys.
All right. Thank you.
All right, our next group is improving osteoporosis screening.
Hi, everyone. So our QI project focused on osteoporosis screening with DEXA scans, and our group members include myself and Kunal, and unfortunately our other two members, one is pre-call and one is post-call. Our supervisor was Dr. Cook. Right. So a little background that we investigated when we were deciding what topic to do. We came across some data. So regarding osteoporosis, 1 out of 5 people die from hip fractures due to osteoporosis, specifically within 1 year of occurrence. In general, I found a very old study, 1995 study said that $13.9 billion were spent on the treatment of osteoporotic fractures, including rehabilitation, surgeries, etc. So that's definitely going to be greater in 2018. The other thing that pointed us in this direction for our project was the fact that so many of our patients are affected by osteoporosis. So most of our patients, unfortunately, are smokers. They drink alcohol. Some are postmenopausal. We have some low body weight patients, and Caucasians, we have many of those patients as well. We also had to go through screening guidelines for osteoporosis, and it depends on what organization or what society you look at regarding guidelines. So the National Osteoporosis Foundation, this is from UpToDate. It recommends all women above 65 and men above 70 should be screened with a DEXA, regardless of anything else in their medical history. Adults who have a fracture after age 50, and then people that have certain conditions like RA or those who are on chronic steroids for a certain amount of time, and then younger postmenopausal women as well. When you look at USPSTF guidelines, it's pretty straightforward. They recommend DEXA scans in women above 65, and most of us know and are familiar with those guidelines. We also wanted to look at, before we started our project, what the insurance coverage would be, because we know our population, a lot of them struggle with financial barriers. So we thought we want to make sure that whatever we're attempting to achieve or increase can actually be feasible for the patient. So often DEXA scans are covered by Medicare Part B. Our aim statement was to reduce overdue DEXA screenings by 20% in our eligible population, which I'll describe our population. It ended up being 53 patients after exclusion criteria. So to reduce overdue DEXA screenings by reaching out to MyChart active patients via EMR and non-MyChart active patients via telephone from January to June of this year. Our population, to describe them a little bit more, I'll go through methods more in detail, but we basically identified 177 patients that were still due for a DEXA and they had not gotten or scheduled one. And those were specifically 65-year-old plus females in our residency clinic. With exclusion criteria, which I'll detail in a bit, 53 patients remained, like I alluded to earlier. Exclusion criteria included a patient that did not have a MyChart account, those who were unfortunately deceased, those with a code status of DNR-CC, and those who had completed a DEXA at an outside facility. We looked at that through Care Everywhere tabs. So when we looked at our data before our study or before our intervention, only 68% of the eligible females above 65 in our clinic population were appropriately screened. And this is a little snapshot of what it looked like when we were trying to find our particular population. And shout out to Dr. Kelber, who I don't think is here right now. He helped us a lot with informatics, and this is just a snapshot for some groups who might have not used Slice or Dice, or how we were able to actually refine our criteria. So female, what age group, how we found our resident population, and then those that were overdue for DEXA. We were able to find that under the health maintenance topic tab. And then we also wanted to make sure that they were people that had MyChart. One of the thought processes behind that was, since we didn't have so much time to get our results, we wanted to do something that would give us quicker results. And this little chart just describes, again, our thought process behind why we did MyChart active patients only. So as we go to the right on this, that means there's more effort for the particular intervention or the particular thing that we're doing. So we figured telephone calling would actually take a lot of time and effort and energy, but the benefits would actually be pretty good if we were able to reach the patient. And then MyChart, we figured it's pretty simple to send a bulk message through MyChart. but it might not be as effective if these older ladies aren't reading their MyChart messages. So this is a little synopsis of our methods. Like I showed you earlier, we used Slicer Dicer in January to refine our population that I mentioned here. We actually sent a letter to IM residents, not a letter, it was an email, but in letter form, just describing our project to get them aware about our project. Our supervisor was Dr. Cook, like I said, and he had to actually obtain access to all patients. When I was showing you the Slicer Dicer slide, you actually don't have access automatically to all Metro Health Medical Center patients, so he actually had to obtain access to that, and that took some time, as well as obtaining access to bulk ordering, which we placed a bulk order for DEXA scans in March. So that's just something to tell all the other residents who are, maybe the interns who are doing QI projects next year, that's something that takes a little extra time, if that's something you're considering. We developed our MyChart message that we wanted to send to our patients, which I will show you a sample of in, I think, the next slide. We got some prelim results, and then we actually decided to call patients who either did not schedule or did not get their DEXA for whatever reason, and we did that twice, and then we got our results this month. So this is a sample of one of the letters that we sent on MyChart. Can't really see it very much. I tried to make it as big as possible, I apologize. But basically, we just introduced ourselves and we said we're resident providers and we care about your bone health. We talked about what osteoporosis is briefly, how you can screen for it, why it's dangerous, why they should care about it, and then how to schedule either online or by phone. And we also, of course, told them that we have went ahead and ordered the DEXA scan so that all they had to do was call or schedule online.
So results. At the end of April, we had 3 out of 9 who actually read the MyChart letter, scheduled a DEXA scan, and they went out and they got the DEXA scan. So the patients that did not read the MyChart message, we called 44 of them, and 5 of them actually completed after the scan. So, you know, the telephone call that we all made at times could have been a little bit, we were trying to have a script with speaking to every patient, so we would say the same thing, but you know, we had to improvise a little bit, and they didn't have a personal relationship with us as the physicians. They weren't sure if it was, you know, a random stranger, but we were trying to say we're the physicians calling them, but the conversations, you know, at times became awkward too as well. So there was a lower rate with the phone call. So this is just the result table just to see that we had 33% with reading just the MyChart message, and with the phone call about 10%. So the potential barriers to scheduling the DEXA, obviously it was time. We did a short period of time to see how long they would follow up and schedule the DEXA. Financial constraints, if they're on financial assistance versus Medicare and Medicaid, which they should typically cover the DEXA. Transportation, with generally elderly women, it may be difficult to get to the hospital and schedule it. And forgetfulness, if they forgot to do the DEXA scan, they may forget to do it again, even if they got a message. Lack of desire, it was a non-urgent phone call. It wasn't a life-threatening thing to get scheduled, so maybe they didn't have the urge to get it. I think another thing was what is active on MyChart. Within a year, I think it would show it was MyChart active, but it was difficult to see if they actually were going into the chart and following up with everything. Future studies and considerations. I mean, our group was only 50 patients, so if we could maybe sending bulk messages out to a patient population that we're trying to get either a study or a lab done would improve the results. I think the osteoporosis DEXA screening may be not on the health maintenance tab. So if the physicians, the primary care physicians are able to see it, they would be screening it more often. And it's grade B evidence per USPSTF. So discussion, similarly with what I said before about the larger sample size, longer time, I discussed that already. And then obviously the perception of getting communication from your PCP versus someone over the phone makes a huge difference too as well. If the PCP was involved too with our project, that would have maybe increased the rate of DEXA screening too. I think another group was actually trying to increase colonoscopies, and they were sending out letters. So I think, if people are not using the electronic MyChart as much, maybe a paper form would increase the rate. And these are our references. And we want to thank Dr. Cook and Dr. Culver for helping us with this project especially. Thank you.
That's it.
Your approach to this is to identify people who should have had a scan but didn't have it already, right? So in other words, you're kind of studying a population you know is going to be difficult already, because now you don't know that they were talked to before, but let's assume they were and they kind of made a decision, I'll think about it, or you either made an active decision not to get it or just didn't follow up. So you're automatically taking a population that kind of is a little tougher. It'd be interesting to see what happens if you either started this earlier or changed the behavior of the first conversation, got the primary care docs involved. You were pointing out that it is difficult calling up as a stranger and talking to these. So what are your thoughts on that? Is in other words, might a different approach have been more effective? Maybe change the nature of the first conversation about the DEXA scan with the patient population, rather than picking the population who had some previous experience with this and it had not followed up with the scan?
It was, I think, getting an appointment with the physician about having the DEXA scan. We bulk ordered it, so they would have had it in their in-basket regardless for every patient that we sent out the MyChart message. So if they saw the DEXA scan in there, they would have already known that, hey, they sent out a MyChart message for this. So hopefully we're thinking that if they had an appointment within the few months, that they would actually discuss it with them.
You're thinking that would have prompted discussion.
Exactly.
Thank you, guys. I just want to mention that you didn't necessarily take credit for this, but the work that you did by identifying this need for to expand slice or dicer to all patients, and to identify this ability to create a report with patients from slice or dice was really valuable, and because of that, next year's class will have the opportunity to do that if you choose, because all of the QI attendings now have that ability. So really, it took some investigative effort to get through that barrier, and so I think it's really going to be helpful for future classes.
All right, guys, thanks.
So before we start this faculty project, if everybody could just get out your cell phones. And, oh no, I lost my, hold on really quick here. Hopefully this will work. Okay, so if you get out your cell phone and prepare to text 22333 and enter in the text box SWANKB888. I didn't choose that. You actually have to pay money if you want to choose your own poll name. Wank B 888 to 22333. All right, and once we're ready, you should pop up a little confirmation. Looks like people have it. Okay, so now if you could please answer this question. When you prescribe opiates, how often do you counsel patients about risk and safety? A, every time, B, most of the time, C, about half the time, and D, rarely, E, never. Just give you a minute or two. It'll populate as you check. So any time. Oh, this is fascinating. Okay, excellent. So about half the time looks like, but many people are having risk discussions, so that's great. I'm going to switch. Please don't let other people's answers bias you. So question 2, let me click it on here. All right. So how helpful is understanding an individual's risk about aberrant use before you prescribe? How helpful is it to you to know how likely people are to misuse? That's great. So we're seeing lots of people think it would be helpful to know something about people's risk. All right, and finally, if a risk score were easily available to you, would you use it to counsel patients about safety of opioid use? There's lots of people drowning you out back there, Dr. Brooks. Or Dr. Watts, I mean. All right, thank you guys. So obviously, what we intended to do was to bring opiate risk assessment and make it easier for patients to use in the hospital. So this is our hospital. We all know this place, and we really began thinking about this project because of this, because Ohio ranks second in the nation for opioid overdose deaths, and obviously we have a clear problem in this county and in this hospital, and so as we were choosing a project, it was natural to think, we need to somehow get involved in this epidemic. Up to 50% of patients who use chronic opioid therapy for non-cancer pain misuse their medications, and 80% of those entering heroin treatment first used an opiate, or their first use was a prescription medication. And I think you've seen this slide showing the concordance and linear relationship between opioid overdose deaths and the number of prescriptions that we give. So on the left here is the number of patients that are annually misusing and abusing opioids in our county, and on the right is annually the number of people who are switching to heroin. So this is my brother-in-law's business in Colorado Springs, Colorado. That's him standing on top of the packed balloon up there. He has an adventure business. He does jeeping, balloon rides, Segway tours, zip lines. And out of all those, which activity, you could just shout it out, do you think has the highest risk of injury? You are correct. Segway tours, right? So the Segway couriers carry the highest risk. There's 1% rate of serious injury. Every guest for all of these tours, not just the Segways, obviously, are informed of the risks and they sign a waiver. Guests undergo a physical fitness and balance test before the activity, and they can be dismissed before, during, or in the middle of the tour if they're a safety risk. So I think the analogy is obvious, right? These are patients who these are people rather who have control over something that could harm them, and so we have an ability to assess that risk, and we have an ability to react based on our judgments and our observations about these people, and so wouldn't we like to be able to do that on a day-to-day basis? And so, but fortunately, we do have a tool. So we'll talk to you a little bit about our thoughts.
All right. So when we started our QI project, we wanted to see what we were up against. So we knew that opiates were being prescribed inpatient without the appropriate screening being done for opiate use disorder. So we did our study on the short stay unit. Short stay unit, it's a closed unit with quick turnover. It's a great place to get a good amount of data in a quick amount of time. So we identified 45 patients that were admitted to the short stay unit in a 1-week period. Out of these patients, 12 patients were prescribed opiates while inpatient. 5 of those patients were prescribed opiates at discharge. And what was remarkable was that none of these patients were identified with opiate use disorder via documentation and the history and physicals, nor were any of these patients screened using the opioid risk tool that's available in EPIC. So we set goals for our study. We were optimistic and ambitious at the onset. Our aim was to achieve 100% screening for opioid abuse risk using the ORT screening tool that's embedded in EPIC. This was for all patients that were admitted to the short stay unit at Metro Health. And we decided to keep the study within the short stay unit. And then our goal was to have this done by June 1st, 2018.
Hello. So we used some of the tools that we learned in the class that we took in the Ohio State University. And one of the first things we did was a Gemba walk. We actually went straight to the source of what our patients were dealing with. So we actually walked through the patient flow from the ED to admission to the short stay unit and looked to see each opportunity that we had for patients interacting with Metro staff where we could screen them, starting from the registration in the emergency department, triaging in the emergency department. The ED nurse takes a screening for the patient, ED resident, ED attending, the floor nurse, medicine resident, medicine attending. So there were multiple opportunities we saw where we could potentially interact with the patient. Then we did our stakeholder analysis to try to see, who all would be interested in this project. And of course, the patients are our #1 priority. We thought of the providers taking care of the patients, our social workers, patients' families, and the administration. And we just started to notice just how complex this problem is, and that even within providers, we're talking about the pharmacists, the primary care physicians, the nurses, the advanced practice providers in the emergency room, medicine, on and on and on. So lots of opportunities, lots of people who would be involved in this project. We did a more extensive root cause analysis, but our basic problem we wanted to look at was patients at high risk for opioid use disorder are being prescribed narcotics. And why is that? And we thought it was either because prescribers were prescribing narcotics and the prescribers were unaware of the patient's risk of opioid use disorder, or they were high-risk patients who needed adequate pain control and narcotics were considered the best option for them. And so, paring down each of these problems, we ended up with looking specifically at
why were prescribers unaware of the patient's risks? And that's because we lack adequate screening tools. Patients may not be open and honest about their history. The screening tools we have may not be very sensitive. And as we all know, there's time constraints in taking care of the patients. So we use that to find possible interventions, and like the previous group did as well, we did a B&E chart, a benefits versus effort analysis of these different interventions that we thought of to figure out which one would have the most benefit with the easiest implementation. And what we came up with was implementing a standard screen using the opioid risk tool. And we'll talk about why we chose that.
So, so what is the ORT, or this opioid screening tool? It's a tool that's been sort of generally adopted. It was initially described in a 2005 paper by chronic pain physicians who looked at their practice, which was about 185, so a small group of patients, and they implemented this screening tool before starting them on narcotic pain meds. And they found that it was quite sensitive and specific in identifying patients, especially those at low and high risk, for their risk. And they measured that by behaviors that they defined as aberrant, which to be honest isn't very well documented in the article, but they mention it are things like requesting early prescriptions, selling their prescriptions, having multiple prescribers, requesting, did I say that already? Intentional overuse, or obviously overdose. And so they did find that it was a good tool because there are other tools that have been introduced, but they're often much lengthier or more complicated, or don't sort of apply specifically to opioid or narcotic abuse, like the CAGE questionnaire, for example. So this is a 10-item questionnaire, and it has a maximum score of 26. You'll see here, I tried to highlight that it is a weighted tool, and they weighted based on sort of accepted knowledge of life experiences that can increase one's risk for addiction and abuse of substances. So you'll see that is the third and fourth columns. There are females and males. For males, having a family history of alcohol and illegal drugs does increase their risk a bit more than a female. But family history of prescription drug abuse increases much more in both. And then a personal history of both alcohol, illegal, and prescription drugs increases their risk as well for aberrant use. And then that history of pre-adolescent sexual abuse is a little more heavily weighted for females. So you can have a total of 26. If your total score is 0 to 3, that's low risk. And this study showed that in those patients deemed low risk, only 1 of 18 showed aberrant behaviors. In the high risk, there are 40 out of 44 patients did display some aberrant behavior, so about 91%. So we decided we'd use it. Even though there's not a ton of data, we thought we could sort of rely on it for the sensitivity and specificity of that small article. So we made this flyer. It was sort of handed out to staff on short stay and residents, and then we also hung it on the short stay unit. And our attempt here was sort of to give a little bit of background about the local problem, to introduce the opioid risk tool, and then to show folks where to find it, because this is actually already in EPIC, and some people may already be using it, especially in the outpatient. Apparently, outpatient clinic was using it earlier. So you can go to flow sheets, you can type in that search box opioid risk, and then you'll be led to this questionnaire that you can then discreetly populate with answers to the questions when you're sitting with the patient talking to them.
All right, so how did we end up doing? And in interest of time, I'll go over this a little bit quickly. So we looked at pre-ORT as well as post-ORT data. The N was 45 in pre-ORT and 37 in the post-ORT. So pre-ORT, we had about 24% of patients were prescribed opiates inpatient. Post-ORT, 35% of patients were prescribed opiates inpatient. So we saw a slight increase post-ORT there. In terms of patients that were prescribed opiates on discharge, 12% of patients pre-ORT, and a decrease of 5% of patients post-ORT. Now, we'd love to say that our implementation is what led to this decrease, but we can't definitively conclude that. In terms of percent of patients who had ORT documentation, it was 0% pre-ORT, and post-ORT, it actually bumped up to 22% of patients were screened using the ORT tool embedded within Epic. And then, surprising or not surprising, in terms of patients physicians who documented risks for opioid use disorder and documented the ORT within their notes was 0% pre-ORT and 0% post-ORT.
So this is just a slide. We realized we had some work to do in trying to spread the word. So we hung these little reminders around the short stay unit and workstations. And we also involved nursing to see if they could help us identify patients that might benefit from both a discussion about their use and the ORT.
All right. Briefly, so barriers to why we didn't have the outcome we would have hoped. We had two different parts of where we're getting the nurses to mainly obtain the ORT data directly from the patient, and then the physicians who were supposed to use this data and document it in their note. We had some trouble getting buy-in from the nursing staff. Partly that was due to our physician-only group. We thought maybe incorporating more a diverse group into that could help solve with that problem with different nurses, staff, and secretaries on the team itself. And also there was an issue regarding, as we mentioned here, QI fatigue, which is really a matter of competing priorities. We had multiple other QI projects going on in the short stay unit at the same time. So during this time period we're implementing this study, there was a variety of different QI projects, so people's efforts were kind of divided. That was also another reason why this project didn't potentially have as much focus on it. In addition to the MD utilization part, we could have the MDs could have utilized this data better as one of the barriers. We could have incorporated different avenues in order to reach them, to understand that this was being done by the nursing staff and that this was available to them. Also, we didn't have a great feedback system for how the nursing staff and the physician staff were interpreting this data and the system we had. So we needed some better way in order to really get feedback from people who are actually using this to see how better we can improve in the future. And I think the last one is the future directions for this, where everyone's going to take a turn.
Yeah, I think we could take questions, but just in the interest of time, I think that we're not sure if we're going to continue the project, but there's, if so, I think the biggest barrier is obtaining reliable feedback and baseline data, since this is a new intervention in Epic.
I think the first question I'd have is about the discrimination and calibration of the prediction tool, because obviously, if it predicts really well, that it might be more helpful than if it doesn't, and what the prevalence of high risk of opioid misuse is, because if it's low, it might actually encourage you to use opioids because you think that these are low-risk patients, so we can wail away with the opioids. It looked like the opioid use went up actually after the intervention in the acute setting. What do you know about the performance of the prediction tool?
So there, there hasn't been a lot of data inpatient. There's some data that's showing reduction in prescription use in ER patients who are screened with this tool. Part of our thought was that it's early, even though the opioid epidemic has been going on for 10 years. We're really just beginning to understand how to evolve to deal with it. So. Yeah.
The ORT, this is kind of an interest of ours too, is what is the screening tool? Is it any good? Does it apply to our patients? And what kind of outcomes, if we were to use it more generally, what would it show similar to that chronic pain practice, that it was sensitive and specific. So if we were to continue this project, that was one of our sort of future directions, was to look at the tool itself and see if it is helpful.
This is great. This is such great work. And I don't know, I'm worried you all aren't perceiving that you're asking these really incredible questions that you don't have the answers to and no one else does. So it feels to me, at least, you know, from outside looking at this project, that what you did at this point is generate what your next cycle should be. I mean, you found so many wonderful pieces that clearly need to be addressed. I hope you don't give up on it. It's real. No, it's true. The reason you have so many questions is because we all have so many questions. It's incredibly useful work. So huge. And really, yeah.
One of our projects is doing this as well as we wanted to create sort of a legacy UI project so that
it's wonderful. And this is specifically about this, you know, there's a lot of data in the VA population, not specifically what you all did, but that was almost my Alabama coming in. But one of the things that the VA saw was that the only way that they really could reduce overall opioid prescribing is by preventing new starts. And it just really struck me in thinking about how many of our new starts actually come out of acute medicine state, potentially, and having no idea about that, where we really do have people who may have specific needs, and maybe that's really an opportunity to help people not get into a situation where they'd have a high-risk tool in the first. Does that make sense? There's a lot of unanswered questions. It's great. Yeah. Yeah, new start. Yeah. 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 Yeah, it's great. And thinking about alternative measures for pain.
The reason I brought up the accuracy of the tool is that that could be the weak link in this. In other words, you could have this is a good intervention if you had a really highly discriminating tool, and if the tool is not discriminating, then having that information isn't that helpful to you. So the idea is right, but the tool may be wrong. You know, you may be on the right track, and it would be worth. Well, the way you develop a tool is you actually get a population, some of whom got addicted and some didn't, and you look at their characteristics overall and see how the characteristics correlate with either addiction or not. I don't know how this tool is. It looks a little simplistic to me. You know, did your mother or father have addiction, or have you ever abused any kind of substance? Actually, that makes sense, and it's kind of got face validity, but I don't know how predictive it is actually. And so it might not be helpful because the tool is flawed, not that the idea is flawed. So that's one thing I'd look into. And this is I think that Brooke is right. This is a complex, multifaceted problem, and it probably isn't solved by a single intervention, right? So that the fact that you put this in, and it's not clear exactly what the results were from this intervention, shouldn't discourage you from trying to work on it, because we do need to figure out how to do a better job in this patient population. And we do have a laboratory here, you could argue, that might be a good place to study it, the short stay unit.
Thank you, everyone. Thanks for staying late.
I was going to close up. Great job. And hey, that polling tool, though. What about that? Oh, sorry, that's all that I really was thinking about the whole time. I was sort of just like, that polling tool. That's really all that I'm.